For more than 50 years, public health agencies in the United States used an unreliable method to decide which syphilis test results to investigate. It's called a reactor grid. Age on one axis, antibody level, which is the titer, on the other. Investigate or close. That was more or less the whole algorithm. And here's the part that really matters. For most of those 50 years, the reactor grid was the best we could do. And this is a story of what it takes to turn data into decisions and what gets missed when you don't. Let me show you. But why does anyone investigate a blood test in the first place? That's because syphilis doesn't stay with one person. It moves through networks. So when public health confirms a case, they don't just treat that one person. They find partners, get them tested and treated, and break the chain before it spreads any further. Done well, that's some of the highest level prevention efforts that we have. But it only works if we investigate the right syphilis test result. By the mid-1970s, around 1.4 million reactive syphilis results were being reported every year, and only about half of them were ever reviewed. There was no way to chase them all, so health departments needed a way to triage, a fast rule to decide which results were worth an investigator's time. And the grid they built to do it stayed in use for the next 50 years. The tool they used to triage is the reactor grid. Younger patient and higher antibody titer, investigate. Older and lower titer, close it. And it mostly worked for most cases, most of the time. Now it's tempting to ask why nobody fixed it sooner. But that framing is wrong. And the real answer is the whole point of this video. The grid did not last for so long because nobody noticed its flaws. People have been studying its limitations for years. It lasted for so long because until recently there was no scalable alternative. To do better, you would need every patient's complete history. And that has to be available instantly. Every prior test, every treatment going back years for thousands of results at once. Now that data didn't exist in a usable form. So a grid that was built on two numbers wasn't laziness. It was the ceiling of what that infrastructure allowed. Which raises the real question. While that grid was running for more than 50 years, how many real syphilis cases was it quietly missing? To understand what the reactor grid was missing, you have to understand why syphilis is one of the hardest diseases to track. It's been called the great imitator because it shows up in other diseases' clothes. A painless sore, a rash weeks later, then nothing, and sometimes for years, while it's still there. And here's the deeper problem. Syphilis is caused by a spirochete, which is a corkscrew bacterium. And we cannot reliably grow them in standard lab culture. So we don't test for the organism, we test for antibodies. And there are two completely different kinds of antibodies that we test for. The first, the treponemal test. That answers one question. Have you ever been infected? Once it turns positive, it usually stays positive for the rest of your life, treated or not. The second, the non-treponemal test. Now that tracks current activity, and its level rises in active infection and falls with treatment. But that second test, the non-treponemal test, that isn't specific to syphilis. It reacts to other things. What other things? Pregnancy, autoimmune conditions, and other infections. So among reactive non-treponemal results, depending on the population, there could be biological false positives. Watch what that means over time. The treponema line goes up and stays up for life. The non-treponema line rises, peaks, and then splits. If you are treated, it falls towards zero. If you're not, it lingers. And there's a third state that breaks simple rules entirely. People who are treated, but whose level settles at a low number and just stays there. Not active infection, not fully resolved, and we call that serofast. So put yourself at the health department. A result comes back reactive. The real question was never, is it positive? The real question is this a brand new infection, a reinfection, an old and treated infection, or a false positive? Or is it a treatment failure? And that is a question, a grid that is built on age and one antibody titer level cannot answer. No two-variable shortcut can. We need the entire history. So why couldn't we just use that history all along? Because for most of the reactor grid's life, that history lived on paper, in folders, in separate systems that just didn't talk to each other. You just couldn't physically pull together one person's entire syphilis history, let alone for thousands of them all at once. And what changed wasn't the medicine, it was the plumbing. Electronic Lab Reporting, ELR. Labs began sending test results to health departments in structured, machine-readable formats. For the first time, a patient's longitudinal history existed in a form that a computer could actually reason through. And at almost the same time, the labs flipped their workflow. They started screening with the automated treponemal tests first. That produced a flood of results, including a lot of discordant ones that needed humans to untangle. More signal, more noise, and a manual review process that was never built for that volume. So here's where we actually were. For the first time, we had the data to do better. And we had a problem big enough that we had to. And that's the gap where I went to work on. During my fellowship at the CDC, we built an automated record search and review algorithm, and we published it in 2021. The idea behind it is almost embarrassingly simple. Instead of using age and titer, the algorithm pulls the patient's entire syphilis history and then reasons through it the same way a trained disease investigator would for thousands of incoming results all at once. Treponemal positive with a new reactive non-treponemal result, that looks like a case. A titer that's climbed fourfold, that definitely points to a new infection. Treated already, but sitting at a low stable level, likely serofasting. We can close that. Treponemal positive, but non-treponemal negative, likely a false positive. None of this logic is new. It's the reasoning a skilled investigator already uses. What was new was encoding that reasoning into a system and pointing it at electronic records, so that what used to take a person hours per case happens for every case effectively at once. Not a smarter shortcut. A system that does the actual reasoning at scale, which leaves the obvious question: does it hold up in the real world? Here is where it gets real. Florida Department of Health implemented that same logic and evaluated against the old reactor grid. Accuracy nearly doubled, from about 44% to 82%. Specificity, which is correctly ruling out cases, jumped from 33 to 79%. Positive predictive value more than doubled. And it freed up close to 8,000 staff hours a year. Those hours could go back into actual prevention. The direction and the size of the effect are hard to ignore. And they're exactly what the design predicted. When you give the system the whole history instead of just two variables, it stops throwing out real cases. And that last part isn't just a statistic. A grid that wrong doesn't just waste time, it closes real cases. We have research asking whether reactor grids let real infections slip through. They do. One study found that nearly a quarter of all reported primary syphilis had titers that were low enough that the reactor grid would have closed them, and we would never investigate them. Higher accuracy in this work isn't an abstraction. It's infections that used to get missed that are now being caught. That's the entire difference between having more data and better systems. Let me take a step back from the algorithm, because the bigger picture makes the case for this work better than any accuracy number can. In the 1940s, we got penicillin. For the first time, syphilis was curable, cheaply and reliably. People genuinely believed that we were about to eliminate it. And for decades, it looked that way. Cases fell and fell. By the early 2000s, syphilis in the US was at a historic low, low enough that the country launched an actual plan to eliminate it. Then this happened. Over the last 20 years, it came roaring back to the highest level since 1950. We've had the cure for 80 years, and there's more syphilis now than at any time since before people watching this were born. Sit with that, because that's the whole point. The cure was never the hard part. We solved the science in the 1940s. What we lost was attention. A cure on a shelf doesn't stop a disease. The system around it does. And that's why work like this matters. Not because the medicine is hard, but because staying ahead of a preventable disease takes systems that keep working long after everyone assumes the problem is solved. When I look back at this work, the thing that stayed with me wasn't the accuracy numbers. It was something simpler. The best informatics solutions don't come from fancier tools. They come from understanding a problem deeply enough that the solution becomes obvious. For more than 50 years, the constraint wasn't intelligence, it was infrastructure. The moment that data existed, the answer was almost simple. Stop guessing from two numbers and reason from the whole history, the same way a good clinician already does. People and process first, technology last. And here's the thing, this was never really about syphilis. That same shape is sitting all over public health and healthcare. Somewhere right now, an expert is doing slow, manual, repetitive review, reading records one at a time, applying judgment that's sound in their head, but invisible to everyone else's. And right next to them, the data to do it better already exists, electronically and unused. Other reportable infections, hepatitis, TB, HIV, chart review for quality measures, case finding, registry curation. The problem keeps the same shape. But this is exactly what the current hype gets wrong. You don't fix it by pouring in more data or bolting on AI and hoping. This algorithm didn't work because it was sophisticated. It worked because we did the unglamorous part. We understood the clinical reasoning deeply enough to encode it. And we built it to fit how the work actually gets done. Skip that, and the smartest models in the world just automates a broken process faster. Do it, and you get something genuinely rare. A system that's faster and rigorous at the same time. It takes off mundane work off of people's plates and adds scientific integrity. Decisions that are consistent, transparent, and auditable instead of living in just an expert's head. Cheaper and more correct is not the usual trade-off, but that's what good informatics actually offers. And it's available across far more of public health and medicine than we have been bothered to build for. That way of working, understanding the system, encoding the reasoning, fitting the workflow, that is the thinking behind what I'm building now, including Sarsa Health. Not to rebuild one algorithm, but to do that kind of work across problems that look just like this one, for real people and in systems that actually work. If that's the kind of thinking you want more of, that's what this channel is. Subscribe, and I'll see you in the next one. And if you want to know what I'm building, sarsa.health.